Supervisor of Public Health Sciences here with the Programs for the Elimination of Cancer Disparities. I'd like to welcome everyone to our 2021, and shall I say 2020 as well, annual Smart Health Community Education event. Unfortunately, we had to be virtual, but I know we will have the most fantastic time as we do in person for this first virtual Smart Health event. So let me tell you a little bit about Smart Health. Smart Health was created to provide our community partners with deeper learning opportunities pertaining to cancer prevention and research to use as a platform to report back on research results and to educate individuals and families about research and its relevance. So this event has been going on ever since 2013, I believe, and it has grown ever since then. So we have a variety of vendors today and wonderful, awesome clinicians and speakers that will provide education on a variety of areas as it relates to cancer and other disease focuses. I just wanted to acknowledge the team coordinating this whole virtual event. For their first virtual event, they did such a wonderful job. Dr. Keisha Wyndham led the charge for coordinating this event. Crystal Johnson and Kiana Jackson. I really appreciate you all pulling this together. Thank you so much.
Thank you. Without further ado, we have Ms. Rebecca Hawkins-Valadez, who is a long-term lung cancer survivor, who is here to share her story about living with lung cancer and how she managed to survive through it. And without further ado, here's Ms. Rebecca.
Okay, I think I'm on. Good morning, everybody. My name is Rebecca Hawkins-Valadez, and I am, among many other things, a lung cancer survivor. I'm going to apologize to you. I am going to read what I wrote down because any of you who know me very well know if I get talking, I just don't stop. So since I have 7 minutes, I'm going to read it to you. Thank you for asking me to share my story. As I said, I'm going to be reading my story to stay within the time constraints. Revisiting my diagnosis, treatment, and care is uncomfortable and frankly painful. However, I believe when we share our stories, it can be of benefit to others who have received a cancer diagnosis. And also, it can be beneficial to the doctors, nurses, and all members of a cancer care team. In 2009, I was working 2 jobs. I was employed as a teaching assistant for students with special needs, and I also worked part-time painting and helping rehab apartment rentals. That July, one evening, I woke in the middle of the night with chills, fever, and nausea. I attributed it to maybe food poisoning. The next day, while riding my bike up a hill, I stopped thinking my tire was flat as I was struggling to get up a hill that I had been doing every day. There was no flat tire. In the following weeks, I became progressively tired. I could not stand certain smells, and I began to lose weight. I knew something was wrong, and intuition told me I had cancer. I went to my primary care doctor and told him I thought I had cancer. He, of course, gave me an odd look. He suggested maybe I was overdoing it. He kept repeating that I looked great. But he did order a chest x-ray at my request and extensive blood work. My chest x-ray was clear. Blood work looked normal. It was then suggested by his nurse when she called me with results that I might have mono. I did not buy that. I requested to be referred to a specialist, at which point my doctor said, "What kind of specialist?" I said, "It did not matter to me." And he sent me to a rheumatologist. She told me she believed my story, but insurance would not cover a CT scan, as I only had an intuitive feeling and there was no hard data that I was presenting with cancer. So she did order more blood work and looked for other things and nothing came up. But within a week of seeing her, I developed what I thought was a cold. And one morning I coughed up a speck of blood, and I mean a speck. I called her office and she said she could order a CT based on that. Well, it showed a tumor in my left lung that had been shadowed by my heart in a traditional X-ray. Things moved very rapidly after that. I had gone 4 months without a diagnosis, and now I was scheduled for a lung biopsy, then a mediastinal biopsy, multiple brain and bone scans, and then I was to be scheduled for surgery for what we thought would be a partial lobectomy. By the time surgery came around, which was pretty quick, the cancer had spread into my pericardium, the lining around my heart. The surgeon removed my left lung totally, and then he did a bovine patch on the pericardium. When he talked to my husband and my family that was there afterwards, he was not optimistic. But then the pathology report came in, and I may pronounce this wrong. It was squamous cell, non-small cell cancer, and they staged me at 2B. The surgeon said the margins that he left were the thickness of a fingernail. I didn't find out till much later how scary that was. I found out 2 years later, however, that he had called the oncologist during the surgery to say things had really spread, progressed much farther than they thought. And if I were 65 instead of 55, he would probably close and suggest palliative care. I'm very grateful my oncologist and my surgeon agreed to continue. Remarkably, I was out of the hospital and home in 3 days. I did not require oxygen at home. I got about a month to heal, then had a port implanted in my chest, and then started chemotherapy treatment that was to last about 4 months, 3 weeks on, 1 week off. But at 3 months, I went in, and as I said, "I am done," my doctor said, "You are done." Because at that point, I was needing blood transfusions. I was not given an optimistic prognosis at that point. And that I did not share with anyone. That was between my oncologist and myself. At 2 years, I finally told my husband, I beat the odds they gave me. They gave me 20 to 80% chance of recurrence within 6 months. But I have been cancer-free for 12 years. I walk, I hike, I swim laps, and I garden. I do whatever I can in the 66-year-old body to keep active. I'm grateful. I'm an artist. I'm a wife. I'm a dog mom. I'm a recovering alcoholic for 14 years and a cancer survivor. Am I a miracle? Well, I think we're all miracles every day. I was very fortunate to have a doctor and doctors who did listen, and I was a partner in my care. Doctors and nurses are humans. They are not gods or magicians. My oncologist asked me early on what I expected of him. I said, "Well, I want you to cure me. I want you to take this away." He looked at me and he said, "I am only an instrument in God's hands, just like you. So let's get to work. 7 minutes is a really short time to share 12 years. So please ask questions. I'm very open about things. If I feel it's too personal, I'll let you know. Thanks for listening.
Rebecca, thank you so much for sharing your stories. Yeah, if you don't mind, could we wait for questions afterwards? After the panelists have stopped, it's just right on time. It looks like our clinicians have joined us. Each panelist, what I would like you to do is kind of introduce yourself a little more. If you want to tell your background a little more, and we are saving all questions that will go in the chat or using an emoji for later. But I do have questions just in case we needed a jump start for any questions at all. All right, so could you go first, Dr. Govindan?
Thank you. Thank you so much for inviting me. I'm a medical oncologist, I specialize in treating lung cancer, and I'm here to talk about very briefly about lung cancer, what it is, and how we approach that, and how we can prevent it briefly. And I suppose I can share my slides. Can I?
Yes, your slides is up. I think they are.
I have it. I can show my own. I just made some minor changes, so I'll show them very briefly. I'll use my own slides. So the point of lung cancer is that 90% of lung cancer is caused by tobacco smoking. And the fact of the matter is that if we all stopped smoking tobacco today, the lung cancer incidence would drop dramatically to less than 1/10 of what it is today. And that, I think, is going to happen eventually, slowly, if not perfectly. But we have come a long way since the early days with the appreciation that smoking causes cancer. In fact, people may be interested to know that one of the very first observations linking tobacco smoking and lung cancer was made here at Washington University by the then medical student working with Dr. Evarts Graham, surgeon back in the 1960s. And then later on, studies proved the association between the two and the causality. And over time, we have appreciated the evil effects of tobacco smoking and have made every effort to discourage teens from starting smoking and also promote smoking cessation at workplaces and also encourage smoking cessation. So I don't think we can say enough about the fact that smoking is the leading cause of cancer. 90% of lung cancer today is caused by smoking tobacco. And over the past 20, 30 years, you've seen a change in the type of lung cancer. In fact, the most common lung cancer we see today is a type called the non-small cell lung cancer. And the less common type is small cell lung cancer. But over the past 20 years, we have seen a little bit drop in the small cell lung cancer, a little bit drop in a type of non-small cell lung cancer called squamous cell cancer. Both are strongly linked to tobacco smoking. And so that actually mirrors what we are seeing in terms of smoking prevalence in this society. And we have been very involved in leading the research on lung cancer, particularly studying how the genes fall apart and lead to cancer. I'll just give you a brief introduction into this. If you really think about the cancer as a disease, that really comes about because the genes inside the cells get messed up. Genes are the chemicals inside the cells that give the message to the cells as what to do. Cells are the basic building blocks in tissues. What happens is that the genes get messed up, and there are about 400 to 500 genes in each and every cell that, when they get messed up, could potentially cause cancer. Every time you smoke tobacco, you inhale about 60 to 70 cancer-causing chemicals, and they all have the potential to mess up the genes in the cells. And that's why tobacco is such a powerful cause of lung cancer, because the lung cells get exposed to that. In fact, 8 years ago, we reported this paper, or 9 years ago, where we looked at patients who had lung cancer, patients who had lung cancer, smokers and non-smokers. And you don't have to know the details of this. The more clutter is there in this figure, that means a lot of genes get messed up. Here, there is very little clutter here that you see, and congestion you see here, and that means there's less gene messed up. So the more you smoke, the more genes get messed up, more likely you have lung cancer. Your lung cancer cells are very much more messed up, to put it in a layperson's language, compared to the non-smoker related lung cancer. I told you earlier on that 90% of lung cancer is caused by tobacco smoking, but 10% is not, and that could be from exposure to radon, chemicals, asbestos, and secondhand tobacco smoking. And then there are some cancers that will happen even if you don't smoke or drink or follow a vegan diet. But that's the nature of life. But then the big news is that we can cut down 90% of lung cancer by stopping smoking. But then we are living with a large population of smokers who have quit smoking, did the right things, and they still are at high risk. In fact, half the patients I see today have quit smoking 10, 20 years ago. And that's where the CT screening comes in. And it turns out that the very low dose CT scan, in other words, you give less radiation, and literally about 5 times less radiation compared to the standard diagnostic CAT scan that we do. And that really is able to identify lung cancers early on. 2 large studies, one done in the US, one done in Europe, both showed that there was a significant decrease in lung cancer related deaths if you really undergo periodic CT screening. And that saves life and decreases the death from lung cancer by more than 25%. And while both males and females both benefit from that, what I really want to emphasize to this group and to pass on the message is that the impact among women is even more striking, quite substantial, even compared to males. And but I do want to have this message very clear here. Lung cancer is preventable from stopping smoking, and CT screening saves lives among former smokers and current smokers, both in men and women, more so in women. So it's very important to get that message across. We do have an organized program, and I'll close with the last slide that it gives all the contact information. And that really helps us identify numbers and everything you can call for arranging the CT screening. But I do want to quickly point out that there is a disparity. And this is a graph that shows that if you look at the Caucasian patients looking at this, we have people coming from all over the city and the metropolitan region. Whereas when it comes to African-American population, that's confined to the BJH neighborhoods. And we are working with Bettina Drake and others to impact, and she's an expert on that. She can inform us more than I can ever do it. And so we are working on various ways, working with a group. And I'm very excited to work with Dr. BC, who is going to be speaking now very soon. She's a world leader in really looking at this area and has published a beautiful paper recently on breast cancer, how to really address the racial disparities in cancer screening. I'm going to recruit her to help us with the lung cancer screening efforts to improve the screening among the African-American population, others. And it is important to know that if you have a stage 1 to 3, we heard a moving story earlier on from Rebecca, and these patients go through grueling surgery and then go through chemotherapy, in some instances radiation, but still we can cure them if you catch them early, stage 1 to 3 even. But that's an important message also to keep in mind. And finally, I'll close with this slide. And who should be screened? And the current recommendations are if you are between the ages of 55 to 77, and if you have smoked 30 packs, we go by the pack history. That means 1 pack for 30 years, 2 pack for 15 years, 3 pack for 10 years. Is the intensity of the exposure that matters. Even if you quit smoking, you'll qualify for it. And talk to your doctor, understand the pros and cons. Now and then when you do the CT scan, we do find some nodules or masses or abnormalities that may not be cancer, that can provoke some anxiety and biopsies, etc. But without a question, CT screening saves lives in these patients. And this is the number you can call. And the Siteman website has all the information. You can Google and say Siteman Cancer Center, lung cancer screening. You'll get all the information. And I hope people spread the word here, and I hope we all work together to decrease the lung cancer-related deaths in this community and beyond. I thank you for your invitation.
Thank you so much, Dr. Govindan. So we are preparing for Dr. BC. Welcome, Dr. BC.
So I was asked to talk about genetic testing in breast cancer. So first of all, genetic testing is basically a medical test that identifies abnormalities in our genes. So we all have genes in us that kind of lead to how we're made up. 50% of our genes come from one parent, while the other 50% comes from the other parent. Doing genetic testing can show genetic conditions or can also help determine if a person is going to be susceptible to developing some disorders that are related to genetic abnormalities. Or even if you have genetic abnormalities, it would give you an indication that you might be able to pass that on to your offsprings. Most of the tests done these days look at many genes, and then they can tell you with some level of precision if you're going to develop certain diseases such as breast cancer, other cancers, cardiovascular conditions, and a whole variety of different medical problems. So hereditary cancers are cancers that are kind of related to genes in the family, which may be passed on from one parent or the other. And red flags for hereditary cancers are if you have multiple family members who had cancers, or if you've had certain cancers of the same type on the same side of the family. So for instance, if many people on the mother side of the family have breast or ovarian cancer, that's a red flag for hereditary breast or ovarian cancer syndrome. If there is a rare cancer in the family, such as male breast cancer, that could indicate that there's perhaps a gene in a certain side of the family. If you develop cancer, or if there's cancer in the family starting at a very young age, because in general, cancer is a disease of the elderly, that could be a red flag. And then if a person has multiple different cancers, so not metastatic cancer, but say somebody has breast cancer, the same person also then develops ovarian cancer, that could be a red flag. And then of course the ancestry of your family. So some ancestries are more prone to develop some cancers. For instance, people who are Ashkenazi Jewish tend to have certain mutations. Some of them have certain mutations that could put them at risk of hereditary breast and ovarian cancer syndromes. So what is actually involved in doing genetic testing for breast cancer and really other cancers? So this is a test that is usually recommended by one's physician, a primary care physician, oncologist, and the genetic counselors are also involved. Usually what goes into this program first is that there is a discussion with the patient about the possible results and the implications on if somebody has a result. It's usually a blood test. Sometimes a saliva test can be done, and most of the time it's billed to insurance. Most of the insurances cover this test, again, depending on what kind of insurance the individual has. The results are usually available within about a month. And then depending on the results, one would need to meet again with the genetic counselor or doctor to go over the results and the implications of the results. So for instance, if somebody's result is positive, then that certainly has implications on screening or management of the cancer if the person has already developed cancer, and then certainly has implications for other family members, because again, if one has an abnormal gene, there's about a 50-50 chance of passing that mutation on to one's children. And not only the children that could be affected, but sisters, brothers, and other close degree family relatives. So these are some of the genes that could be abnormal and are implicated in breast cancer development specifically. You might have heard of the BRCA1 and 2 genes. So if somebody has a mutation in either of those genes, there's about approximately a 50% chance of developing breast cancer over one's entire lifetime. There's also a gene called PALB2 and CHEK2. And then there's several other genes which are less likely to lead to breast cancer, but still higher. than if somebody did not have any abnormality in those genes. But again, these are the four top genes that could lead to breast cancer. So so we usually follow certain guidelines to determine who is eligible for our genetic testing for breast cancer. These guidelines could be somewhat complicated, but I've just tried to summarize them very briefly. So in general, anybody who's developed breast cancer at an early age, generally at or under the age of 45 years old, if somebody has two separate breast cancers, so one in either breast, one in both breasts, I mean, or if somebody has two different kinds of cancer. So for instance, if you have breast cancer and you also have ovarian cancer, that would be an indication for genetic testing. If somebody has advanced stage 4 or metastatic breast cancer, that's also an indication for genetic testing, because there are actually some medications that are used for patients who have BRCA1 and 2 mutations with stage 4 breast cancer. And then, like I mentioned before, if there are multiple family members with breast or ovarian cancer, one needs to consider genetic testing, even if one is not affected. If there's a male in the family with breast cancer, that is an indication for other family members, as well as the male, of course, to be checked. And then really anyone who wants to understand their risks better, particularly if they have, concerning cancers in the family, that could be an indication for testing as well. And then recently there was a study actually showing that patients who have BRCA1 or 2 mutations with early breast cancer benefit from a medication called olaparib. So I think over the next couple of months to years, very soon, we're going to start testing, I would say, most patients who have early breast cancer for these mutations, just because of the new study showing that they benefit from a certain medication. So here at Siteman, we performed a study a couple of years ago, just trying to look to see if the current guidelines that we follow actually are working well enough for African-American patients. And so what we did was that we recruited 250 African-American patients around the St. Louis area and sort of tried to evaluate what had been done as part of their medical care. And so what we found was that of those patients who were eligible for testing, about only 60%, less than 60%, had actually had genetic testing as part of their routine medical care, suggesting that 40% who should have been tested would not have received the care that we would give those patients who would have been found to have a mutation. So there's definitely a racial disparity going on in genetic testing. And this is something that we're looking at closely at Siteman. We're looking at ways to reduce the disparities in genetic testing. So why is this important to consider genetic testing? Well, there are a number of reasons. For instance, the first reason, like I mentioned, would be it gives information on the risk of developing cancers. So if, for instance, if I have in my family sisters, mother, maternal aunt with breast cancer, that's very suspicious. One would really want to know if this can be prevented in other people in the family. And so doing genetic testing and finding a gene will lead to more intense screening in individuals who have these mutations. People who have mutations can also take medications to prevent breast cancer. And there are also some preventive surgeries that can be done for people who are at very high risk of developing breast and ovarian cancers. And then, of course, if somebody has breast cancer and is known to have these mutations, there are actually some treatments that are specifically for those patients. So again, the targeted medications for those specific mutations, what I just mentioned. And then it offers information regarding families, other members in the family about their risk for developing breast cancer. So these family members can also get tested, take charge of their care. And if they have these mutations, then they can take the preventive medications, surgeries, or also enhanced screening with mammograms or MRIs if they don't want to have prophylactic surgeries. So it's very important for African Americans to be involved in clinical trials. All these genes that we have identified that lead to breast cancer, including BRCA1, 2, and the other ones I mentioned, these genes were really identified based on studies largely involving white patients. So we don't really know the full picture in Black people because, Black people, African Americans, are less likely to participate in clinical trials involving medications or even genetic testing, really for a wide variety of reasons. And then the other problem we see is that when we get genetic testing, so there are a couple of outcomes that could happen with genetic testing. The result could be negative, the result could be positive, and then the result could be inconclusive. Blacks, unfortunately, are more likely to have these inconclusive results. We call them variants of undetermined significance. Again, just because the whole picture is not really all that clear in Black patients. And again, this ties into the fact that most of the studies were done in whites. And so if we see a certain gene that we're not really sure of if it causes cancer or not, that gene is termed a variant of undetermined significance. So this really, so participating in clinical trials and contributing to research gives us a better idea of the risks of Blacks and what genes really lead to cancers in Blacks. Thank you.
Well, thank you so much, Dr. Bisi and Dr. Govindan. We do have a couple of questions in the chat. So Dr. Bisi, since you were last, there's a couple of questions. I'm gonna go backwards here for you. Someone asked about the genetic testing and what insurance would cover it.
It really depends on the insurance the individual has. At least for breast cancer patients, most of the insurances cover. So Medicaid, Medicare, again, it depends on the state. Private insurances are also pretty good. So there's generally coverage for most patients with breast cancer.
Okay. Then another question asks, were there males recruited? How many males were recruited in your study?
Oh, we had just 250 women. Women alone were, were the patients we targeted. Again, just because breast cancer is just much more common in men than women.
Okay, and this also can go for Dr. Govindan also. Did you have any males in your study, in your lung cancer study?
Of course, yeah. Substantial number of them. Over half of them are males, 50%.
Okay. So another question we'll ask, and it could go to either one of you, is there a program or educational information available for patients to have conversations with their family members about genetics and predispositions?
This is a very good question. There's actually one of our researchers, Dr. Hagman, trying to study that because there's no, as far as I know, there's no formal program other than, consultation with physicians and genetic counselors. So when a patient is found to have a deleterious mutation, an abnormal mutation, that patient is generally so the family members are generally invited to also meet with a genetic counselor to speak with them, go over their risks, and then kind of advise them as to how they should also be tested. So usually through genetic counseling.
So we have a very well-developed program, pamphlets, and promotional material that are given out in printed form to physicians and the families and the patients, so they can have this conversation. There's also in the website, Siteman Cancer website, there is that information. All people have to do is lung cancer screening, and it's available there.
Thank you. So another question came through. They want to know, how has lung cancer screening programs affected the marketed disparity between lung cancer diagnosis in white and Black populations in St. Louis?
It's a little too early. The whole idea of that is if done properly, you will have a slight increase in stage 1 and 2 cancers, mostly stage 1, I would presume, over time. And since these have been approved only recently, and by the way, by the act of law, these preventive screening measures are mandated from the health insurance partners, and they are supposed to cover for them. And so we will see the impact over time. It's a little too early to see the clinical impact. Eventually, we will see. Current theme is that we see patients mostly, only a third of our patients have stage 1 or 2 lung cancer. Hopefully that number will increase closer to 50%. Second, there is a little bit of a disparity where we see slightly more advanced cancer patients among the African Americans, and that number hopefully will equalize or become a little less over time. And I think it's a little too early to see, but it's a good question.
So someone asked about the resources, some of the support organizations. Are you connected to any of the support organizations in the community?
So the lung cancer research, there are a lot of these groups that are interested in smoking cessation, tobacco related cancer, lung cancer research, and the lung cancer research group is they work with me on, and there are a lot of efforts that are happening at the cancer center level to partner with local groups. And can we do more work in this area? Of course, yes. And it is something that we're beginning to do more and more.
Okay. So I do have a question. I know in several areas, not just in this area, in regards of clinical trials, there is some difficulties at time to recruit people of color in your trials. What are you doing to express the importance of clinical trials for prevention?
It's a great, the treatment trials, there are two parts. We as oncologists, Dr. BC and myself and others, as treating physicians, we end up seeing patients who have an established cancer more than patients who don't have cancer. And in my opinion, and my 25 years of experience dealing with large numbers of patients with lung cancer, my observations are the following things. Yes, it is true that there is reluctance among certain sections of our population to participate in clinical trials of any kind. I can only speak with confidence about the treatment trials, not so much prevention trials. I'm not involved in them, but I think the same rules apply. Number one, I think the individual patients, whether they are African Americans or other colored or not colored, they actually have to have a rapport. So I have been very successful in recruiting patients of color in all my clinical trials, partly because they see you. Once they see you as somebody truly caring about them, then they follow your advice. So I think that's true, regardless of the race or ethnicity. And the rapport is very, very crucial. So I think that's important. I think the physician-patient relationship, in my opinion, is the single most important thing. If it is not there, in my opinion, very little things can prop that up. And the second, we also can do other things that have been shown to be helpful, is having navigators that can help them navigate through that. Participating in clinical trial in part depends on the trust relationship, the historic wrongs that have been done in the past, and overcoming those concerns the community appropriately has, and also navigating through challenges in coming to the clinic 5 times, getting 4 different x-rays and scans that are necessary these days. And I think having navigators that they can resort to, and especially having navigators they can relate to, I think it's very, very critical, and most programs have that, and I think we do have. And finally, I do think we have to periodically ask them. There's no point in presuming that you know the answers. And in fact, we are doing a similar attempt with one of our physicians in North County. And in fact, I just met with them, Dr. Davis. He's going to be working with us and Dr. BC, and to get understanding. I like to do periodic surveys on the population. And these things change over time. So we got to figure out what the current demands are and the current generations of patients in the current context and what are their concerns. And I think we have to do those things, and we are doing that as well. So I would encourage our physicians to do the best for the patients, and all of them do their best. And we need to reach out to them even more and explain to them at the level they can understand. I think it's important to gain the confidence, use navigators, and then periodically probe them and see what else we can do. And any thoughts, PC?
The other thing I just wanted to add is that, some of the very large clinical trials run by large organizations, the NIH and other bodies, traditionally have had very restrictive eligibility criteria for entering the clinical trial. And some of the eligibility criteria have been problematic for certain groups of patients. So I think, a lot of people are trying to figure out how to make clinical trials kind of more inclusive for all populations. So for instance, in general, we know that African Americans tend to have, some African Americans tend to have more medical problems than, their counterpart white patients in terms of, high blood pressure, diabetes, other things. And some of these things could exclude patients from clinical trials. So that's one big part of the picture also that is being really looked at.
Thank you. I have a couple of questions for Rebecca. So Rebecca, it's asked, what are some of the coping mechanisms you use to manage your illness?
Oh boy. Well, I think I was fortunate in the fact that I am a recovering alcoholic. At the time that I got my diagnosis, I think I was 3-4 months shy of being 2 years sober from alcohol addiction. So I had my support group there with friends who were going through that with me. And to me, that will always be my primary disease because I believe it is a disease. So I, was part of a 12-step recovery program. So I had to look at my cancer diagnosis and the journey that I was entering into with the same kind of toolkit that I did for alcohol. And that was that I had to accept where I was completely. I couldn't go into denial about any of it. I had to trust in people who knew more than I did, because believe me, the type of person that I am, if I think I can fix it, I'm not going to call somebody to help me. But I, try as I might, I could not figure out how to cure my cancer. And I had to trust these complete strangers in my my surgeon and my oncologist. But what I did, which I think unnerved them both, was I said, we're not doing anything till we all get on the same page. I want a consultation with you. I want a consultation with you. I want to be informed on everything that's going to happen. And thankfully, they had worked very closely with each other before. So, but when it came to like going through my chemotherapy, I made the choice, a lot of times people say, well, take someone along with you and have you sit with you while you do that. I decided I did not want to have anybody that was close to me that I loved or that loved me to see me, to witness that. I didn't know how I would react emotionally or physically. So what I wouldn't accept a ride from people. I went on, a service that was through the community cancer center where I got my chemo. A stranger picked me up and a stranger brought me home. And I got another friend at the end of 3 months. But I got to know the people that were receiving chemotherapy at the same time. And it was mostly women. I assumed they all had breast cancer. And as it turns out, we were all in there for the similar thing, lung cancer. And I was the only one out of 8 that had ever smoked. So and I'm also the only one out of that 8 that is still alive. So as far as support groups, they had a cancer support group, but they kind of threw everybody with any diagnosis into the same group. And I think, I don't know how to say this. I think lung cancer really makes people uncomfortable. I think they immediately think, you're the Walking Dead or something. And also the first thing that would come out of somebody's mouth at those meetings was, well, did you smoke? Which I didn't hear, did you smoke? What I heard was, well, it's your fault. And so I could not find a support group for lung cancer patients that I felt was looking at me as a human being who was going through a terrible trauma and trying my best. I also did not find really support for my husband and I as a couple. I think one thing that was tremendously difficult going through it, surgery is one thing, going through chemo is another thing, but to watch this person that you love and loves you, their heart is breaking. They are helpless. I think it was much, much harder for my husband emotionally than it was for me. But the other things I did things against the suggestion of my oncologist. He told me to stay home, stay safe, wear a mask, don't go around people. And after 2 months of intense chemotherapy, I just went, this is not working for me. I was getting depressed. I started smoking again. And so one day I put on a mask and I bundled up and I went out and got on the bus and I took it up the hill to downtown and I walked downhill. And I started doing that and I started walking every day and I started going out and getting my own groceries. And I got I had to get rid of that feeling that I was a liability, that I was an invalid, and because I was not. I mean, and if you went back and talked to my intensive care unit team, there's a good reason why I got out of there in 3 days, because I was driving them crazy, because I wanted to get up and start walking the night of my surgery. I said, I'm not going to lay here. I am not going to accept this. I can breathe and I want to move. So my thing has always been, it's hard to hit a moving target.
Thank you so much, Rebecca. That was wonderful sharing that information. And get the other question that was going to be asked to you. You already answered it about the resources that was available for you. So I have a question also for Dr. BC again, and this can also go for Dr. Govindan. We do have our PCAT outreach team, and someone wanted to know is what can the outreach workers do to encourage clinical trials among African Americans and other minority groups?
I think really the most important thing I would say is really education and information. Just trying to educate the public about the benefits of participating in clinical trials. I think some people view participating in clinical trials as being guinea pigs, but that's not really the situation, at least in this current time. Many of all the clinical trials are extremely regulated, so we're not really using participants as guinea pigs. And in fact, many clinical trials, the only way to get very cutting edge newer therapies is to participate in clinical trials. So, and studies have shown that caring for cancer patients tends to be better on a clinical trial rather than, just receiving the usual standard of care therapy. So it's very important, like I said, for people to participate in clinical trials. The other thing is just, being there to answer questions and allay fears and explain the whole process, and also give people an understanding of what kind of resources are available. For instance, if we explain to people about clinical trials, sometimes they're a little bit more involved and they might need, like Dr. Govindan said, to come, 5 times instead of 2 times. Just understanding that there are resources for transportation. Sometimes there are resources for accommodation, just little things that the physician may not think about, but these health workers can explain to patients and educate them that there are a lot of community resources for patients nowadays.
Wonderful. Thank you so much. Dr. Govindan, someone is asking about the requirements for a low-dose CT scan.
As I said, the age 55 to 77 and 30 pack of tobacco smoking, it depends on if you smoke a pack for 30 years, that's 30 pack, or if you smoke 3 packs for 10 years, that's 30 packs. So that's the current recommendations. And that may change with time. And it's always a good idea to talk to the primary care physicians because you may have other issues. And, if somebody is going through advanced colorectal cancer treatment and are going through chemotherapy, screening them for lung cancer does not really make much sense because your focus is on treating an existing cancer. And so you have to have, or you have an advanced heart failure where you have a very little, reserve in the heart function, then the focus ought to be on treating the heart failure rather than going and looking for a very early stage cancers. And so I think the primary care physicians can help you sort this out, but those are foreign, those are not very common. Vast majority of our patients would qualify for this. The age range is 55 to 77, 30 package of tobacco smoking. Just 2 things to keep in mind.
Okay. So the floor is still open to answer questions. You can either come off unmute if you'd like to ask your questions or put it in the chat. So my question also, although you have this guideline requirement or suggestion for your screening and the CT scan of 55 to 77, have there ever been a point that a younger person, younger than 55, that was experiencing somewhat symptoms could be lung cancer?
Sure. I think that there are 2 different issues. We are talking here about patients who have no symptoms, screening them, and that's what this applies to. At any age, if there are symptoms that are concerning, the physicians would order a series of tests. Of course, if you have cough for a few days, getting a CT scan may be too much. They'll all be evaluated. The physicians have an approach to that. Cough is very common these days. The bigger concern would be, could this be related to COVID? And so there are various ways to approach that. So I would not recommend getting a CT scan the moment you have cough or have some shortness of breath. There are different things that physicians would do. So symptom-driven cancers are approached where symptoms are approached in a different way. We are now talking about healthy asymptomatic patients who are at high risk for lung cancer.
I don't know if you addressed this, and you probably did, about the different stages of lung cancer. Could you kind of go through those different stages?
Sure. Stage 1 lung cancer means it's all confined to the lung. And typically they are small tumors. They can be removed as long as the patient is fit and the rest of the lung can withstand the operation. The stage 2 lung cancers in general are those that have gone from the lungs to the lymph nodes within the lung. And I'm making this a little too simple here, but that's in general, that's how this works. And these cancers have spread from the lungs to the lymph nodes within the lungs. The lymph nodes are those structures in the body that help fight infections, promote inflammation, and try to keep us generally healthy. And then stage 3 is when your cancer has gone from the lungs to the lymph nodes in between the two lungs, an area called mediastinum. That's an area separating between the two lungs. And when a cancer cell travels, or cancer cells travel from the primary tumor to the big lymph nodes in the space between the two lungs, that it's one more step up. And stage 4 is when the cancer has spread to the other lung or to other parts of the body, like a brain, lung, bone, etc., liver, adrenal gland, a gland above the kidneys. And those are obviously quite advanced. So if you have a stage 1 or 2 lung cancer, the general approach is to consider operation, as long as you are fit for the operation and as you can live without that part of the lung. So those are the two things we look for. If for some reason we cannot go for surgery, stage 1 or 2 patients these days are increasingly treated with a very fine-tuned radiation, which is a pinpoint radiation directed to the tumor given over 3-5 days to 7 days. And if you have a stage 3 lung cancer, that is a cancer going from the lungs to the glands in between the two lungs, an area between the two lungs, we treat these patients with chemotherapy and radiation followed by immune therapy. And that actually is a recent advance that is adding immunotherapy to radiation treatment that has increased the cure rate to about 50% or more. So that's a substantial improvement compared to what we had 15 years ago. In general, operation does not help patients with stage 3 lung cancer, that there are exceptions to the rule. Stage 4 patients are typically treated with the medical therapies. And we do use radiation if the cancer is spread to the brain or it is in the bones. And occasionally we do surgery too. But majority of these patients are treated with medical therapies. In the past, it used to be synonymous with chemotherapy, but today we use the 2 other forms of therapy apart from chemotherapy. Chemotherapy drugs are given intravenously, mostly, sometimes orally. They go through the bloodstream, kill any rapidly growing cells. The 2 other forms of treatments are what we call targeted therapies, where we try to figure out what genes are driving this cancer and trying to turn off those genes. Even though there are 300 to 500 genes that can cause cancer when they get messed up, we have drugs only for about a dozen of them. For lung cancer, about 9 of them. So we use those drugs specifically for those particular tumors driven by that particular gene alterations. And then the very new form of therapy today in stage 4 non-small cell lung cancer setting is using immune therapies, where basically we take the foot off the brakes of the immune system and let your immune system kill the cancer cells. And that has been quite dramatic. And I have patients with stage 4 lung cancer who have even been cured with immunotherapy. There are small numbers, but the fact that even we have small numbers of those patients gives us hope that we can do more investigations and try to have better and better forms of therapy. In this instance, I would point out a few things. That Washington University, this is somewhat like a marketing plug, but I do want our community to be proud of this. PET scan was invented here at Washington University. As I told you before, the very first link between tobacco smoking and lung cancer was appreciated by us nearly 50 years ago. And then we were the first in the world, actually one of the 4 institutions in the world that mapped out the human genome, which is almost like man going to the moon project, mapping up all the genes in the human being. And Washington University did 1/4 of the work. And it's that way it's a pioneer in mapping the genes in the human cells. And then we also were the first in the world to map out completely all the genes in a cancer patient. This was a monumental effort published 12 years ago in a patient, African-American patient with leukemia. And that is the first time ever that feat was accomplished. Now it's being done by many, many people now, but we were the pioneers in this. We also contributed significantly to help us understand how we can harness the immune system to fight the cancer cells. And that basic work was done here by my colleague, Bob Schreiber. So our citizens in St. Louis and the metropolitan area in Missouri and Illinois should be proud of access to a top-notch care in St. Louis through Washington University and its affiliated network centers and Siteman Cancer Center with Barnes Jewish Hospital. And we want to make sure that our community reaps the full benefit of all of it.
Thank you. I have one more question, and then we are going to get ready to go to our break. So Mr. Slaughter is asking about what percentage of secondhand smoke, if any, can cause lung cancer, and has a study been done with secondhand smoke associated with lung cancer?
That's a great question. If you want to award a greatest question prize, this would be it. And what does secondhand smoking do? You know, this is a topic that I personally study in my own research. That's why I said the greatest question. It is the greatest question that we are all facing now. How does it really impact lung cancer? You know, it's very hard to say, you know, but it is possible that if you've been exposed to a lifelong you know, if you live with a parent who smoked like a chimney and or parents, you know, in the formative years, those side stream tobacco smoke could potentially go in. Smoke is a smoke at the end of the day and can cause the changes in the cells. And we are now trying, the technology is advanced to the extent that now we can take a patient's tumor cells and map out the genes. And through that analysis, we can even figure out, did tobacco smoke cause this cancer? And it's almost like a forensic exercise. You can go back and see who caused that crime and what caused that crime, what caused the change. And we're able to find that. Of course, if you give me a random set of tumors, and if you don't tell me whether this patient is smoker or non-smoker, if we do the genetic mapping, we can say with 100% accuracy, this came from a smoker. It is that good, the technology today. And we've used that recently in a paper that we are just about to publish. We analyzed 200 plus never smokers with lung cancers, and we asked them, could any of them have hidden signature of smoking? And we really didn't find it in anybody. And that doesn't mean that the secondhand smoking does not cause this. My own feeling is that the secondhand smoking, it's not like a one basket. It's a much more nuanced. And you know, if you sit there in a bar somewhere and somebody's smoking next to that, you're not going to get lung cancer 10 years down the line because of that one evening. But if you get exposed to secondhand smoking continually for many, 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 many years, it's possible it could have an impact on it. But what complicates everything is that patients don't have that kind of a recall, and patients don't have that kind of an information, or at least we don't gather, I should say more correctly. We physicians don't gather that information. So it's hard to tease out. My feeling is that exposure to secondhand smoking could be dangerous, not from the lung cancer, but for the cardiovascular and other events. And in fact, people used to report the moment the ban went on public smoking in New York, the incidence of acute, the emergency visits to the emergency rooms for heart attack dropped down significantly within even a few months to several months. So I do think there are some very good reasons why people should not be exposed to secondhand smoking in a persistent, constant fashion. And if you pass by somebody who's smoking casually, I don't think it matters. But I think the key is really persistent exposure probably is not a good idea. It's very hard to answer the question. That's why these are great questions. We don't have a good, easy answers. If they play a role, that plays a small role in my view in the non-smokers, but it is a good thing to avoid.
Thank you, Dr. Govindan. Dr. Bisi, did you have anything to add or ask?
No, not really. It's a great session.
Absolutely. So the takeaway from this session is, in general, is early detection with the screenings. You know, you want to be more proactive with being screened for the early detection as well as education. So we would love to thank our speakers for your wonderful presentation today and the dialogue and being engaged into the dialogue. Thanking our participants for that. We want to thank Rebecca for sharing her wonderful story with all of us, and hope we've learned from that as well. So a little bit early going into our break time. So we have about a 5-minute break, and then we will be transitioning into breakout rooms. So if there is one last burning question, you have 2 minutes.
You know, there is somebody asked a question in the chat room about the PATH study. That's the link between FDA and the National Institute of Health to ask the question about tobacco-related health. And it's a great study where at the population level, looking at the assessment of tobacco and the impact on the health beyond cancer. we always focus on cancer when it comes to this, or by nature, I get invited to this cancer talk, so maybe I'm focused here. But in reality, tobacco really causes huge amounts of damage, not just the cancer, by causing damage to COPD. In fact, I cannot tell you how many patients I've had in my last 25 years who have been cured of lung cancer, died of COPD over time because of the damage from tobacco smoking, or heart attack, stroke, peripheral vascular disease requiring amputation. And so I think this is where really getting away from that, from the exposure, especially in the teens, which is where I really think we ought to focus our efforts on, because once they get hooked on as a teen, it's very hard to get them away from this. And in fact, that's the hardest group for tobacco cessation efforts. And I think we should just do everything we can to decrease that exposure in the early teen years. And so I think it's a great study. Thanks for bringing this attention, Carlette. And I'm not primarily involved in this. Several institutions are involved in this, and it's definitely something. It's a great study, and hopefully we'll learn quite a bit in the coming years.
I just have one question to ask. We've been talking about cigarette smoking, but we didn't address vaping. So how does vaping contribute to the risk of lung cancer?
Again, that's a great question too. And the problem is that there are two parts to that. The nicotine is a substance that goes into the bloodstream and then stimulates some cells in the brain, and that gets then release a chemical called dopamine, and that that gives you that pleasurable sensation or a kick. And nicotine is an addictive substance, and nicotine by itself does not cause cancer. And there is some evidence that it may, but that's not the dominant cause of cancer. The lung cancer is caused not by the nicotine, but it's the burning of that. And the burning itself causes exposure to all the cancer-causing chemicals. And so potentially, if you don't smoke tobacco, you may not get lung cancer that high. But then chewers of tobacco, they get, because of the effects of that in the local cells, they get a different form of cancer. And vaping, it's not known how safe it is, how much it will decrease the lung cancer. We don't know that at the moment. But vaping also has lots of other things that can cause the damage to the lungs. Addiction to the nicotine in turn can transfer the person from vaping to actual smoking. Nicotine definitely causes blood vessel spasm, and that can lead to stroke, heart attack, peripheral vascular disease. And I have to say, even though it avoids the smoking and the related carcinogenesis and cancer-causing chemical production, I have to say I'm not very excited about that, because it's getting addicted to tobacco by a different way, and I'm not a big fan of that personally, and I would not recommend that.
Great. Well, thank you so much, Dr. BC and Dr. Govindan. We are about 1 minute behind, but I am welcoming people to stay in the general room as you go to your 5-minute break and come back. And I believe you'll be able to choose what breakout session you want to go in, but you're welcome to stay in this room to ask questions, additional questions if you like. Yes, Dr. Govindan.
Thank you for having me. Thank you. Thank you so much.
Absolutely. Thank you for coming and presenting such great information.